Dear audience, let me introduce my PhD topic, which is novel insights into the oral systemic health axis. My name is Ellay Gutmacher. I'm a first-year PhD student and a fourth-year dental student. My supervisors are Andrea Brody and Akos Jemberi. My SMS is Petrana Martinakova. My statisticians are Silvia Kish-Dalla and Gergely Agoch. My vision is to facilitate global healthcare by better understanding the oral systemic health axis. And my mission is to do it by providing an evidence that saliva can detect systemic diseases. Currently, we have 3 ongoing projects. 2 of them are meta-analysis, and 1 is a clinical observational trial. Due to time limit, I will only talk about the first 2, but the last one is evaluating the diagnostic accuracy of salivary C-reactive protein in neonatal sepsis. Our first project is investigating the salivary levels of Fusobacterium nucleatum in patients with colorectal cancer by the methodology of systematic review and meta-analysis. This project has started in September last year, and the co-author for this project is Balin Jombor Sarai. Colorectal cancer is responsible for more than 930,000 deaths per year, and it is estimated to increase to more than 1.6 million deaths by 2040. Screening tests such as colonoscopy can prevent early colorectal cancer by detecting malignant polyps and removing them. However, the accessibility to colonoscopy is limited by geographic barriers, and this contributes to the late diagnosis. In addition, it is an invasive, uncomfortable, and potentially harmful procedure. As an example, in the USA, nearly 22 million risk individuals have never been screened for colorectal cancer. We know that Fusobacterium nucleatum is an oral pathogenic bacteria that is associated with periodontitis. It was found that the bacteria accelerates different types of cancer, such as breast and pancreatic cancer. Recent studies showed that the bacteria is found in colorectal tissues of patients with colorectal cancer and polyposis. And the higher the abundance of the bacteria in those tissues, the lower the survival rate of the patient. Therefore, we suggest a novel method to detect colorectal cancer using saliva samples from which we can measure the DNA levels of Fusobacterium nucleatum. Our vision is that risk individuals would be able to diagnose themselves from home, and by that we provide an excellent tool to increase the detection rate of colorectal cancer. This is why our aim is to investigate the diagnostic and prognostic value of salivary Fusobacterium nucleatum to detect colorectal cancer patients. So we ask, is there a difference between colorectal cancer and healthy or precancerous patients in the salivary Fusobacterium nucleatum DNA levels? To answer it, we use the PECO and the PERT framework. The PECO framework to investigate the association between salivary Fusobacterium nucleatum and colorectal cancer patients, and for that we hypothesized that patients with colorectal cancer have significantly higher levels of salivary Fusobacterium nucleatum than healthy individuals as well as precancerous patients. To investigate the diagnostic accuracy of salivary Fusobacterium nucleatum to detect colorectal cancer patients, we use the PERT framework, and for that we hypothesized that salivary Fusobacterium nucleatum can accurately diagnose colorectal cancer patients. We conducted our systematic search on November 25 last year in 4 databases with the following search key that is composed of 4 domains. And we started with nearly 14,000 studies, and currently we have 12 eligible full texts. Let me introduce our results. Here, we investigated the presence of Fusobacterium nucleatum in the saliva among colorectal cancer patients and control groups. This is important because patients with colorectal cancer usually show symptoms at the late stages of the disease. Early detection can open up more treatment options, and also to increase the likelihood of the successful outcomes. And by that, it can save lives. So to assess this outcome, we use the odds ratio with 95% confidence interval. And we included 5 prospective cohort and case control studies with nearly 1,000 patients divided into 2 subgroups, the healthy and the polyposis patients. The heterogeneity was 0%, which is very low heterogeneity between the studies. And the pooled odds ratio for the presence of Fusobacterium nucleatum in the saliva is 43% higher in patients with colorectal cancer. And this could be clinically relevant. However, it did not reach the statistical significance. Here, we investigated the relative abundance of Fusobacterium nucleatum in the saliva among colorectal cancer patients and control groups. And to assess this outcome, we used the mean difference with 95% confidence interval. And here we also included 5 prospective cohort and case control studies with nearly 500 patients. The heterogeneity was also 0%, and the pooled mean difference for the relative abundance of Fusobacterium nucleatum in the saliva is minus 0.04%, which is neither statistically nor clinically relevant. The strength of our study is its novelty. It focuses on vulnerable population. We could include individual patients' data, which allowed us to interpret further the results using different variables. And we also included studies from diverse continents. The limitations were the different measurement of salivary Fusobacterium nucleatum and the low number of the eligible studies. So based on our results, we can conclude that the presence and relative abundance of salivary Fusobacterium nucleatum are not associated with colorectal cancer. For the practice, we imply that salivary Fusobacterium nucleatum alone as a biomarker for colorectal cancer should not be recommended. And for the research, we imply that more studies are needed, more unified measurement of salivary Fusobacterium nucleatum, and other non-invasive markers that can replace colonoscopy should be investigated. Currently, we are working on the manuscripts, and we plan to submit our project to the Journal of Dental Research at the end of the month. And let me introduce our second project, which is investigating the diagnostic accuracy of salivary procalcitonin in bacterial-induced systemic inflammation by the methodology of clinical observational trial. This has started in November last year. We know that bacterial infections are responsible for more than 50% of the infections in the intensive care unit. Infections in those patients are associated with high morbidity, high mortality, and high cost. The current used method to detect the source of infection is bacterial culture, but this is a slow method. It may take several days to get an answer. And quite frequently, it gets contaminated, which makes the sample inefficient. Therefore, diagnostic strategies to exclude the presence of infection are much needed. Serum procalcitonin is a sensitive marker for bacterial infection. By excluding bacterial infection, it can reduce the excessive use of antibiotics, and by that, it can fight antibiotic resistance. Studies showed that the procalcitonin is higher in the saliva of patients with periodontal disease and also during the exacerbation of COPD. So our aim is to investigate the diagnostic accuracy of salivary procalcitonin for bacterial-induced systemic inflammation. Our first clinical question is, how does salivary procalcitonin correlate with serum procalcitonin in patients with suspected bacterial infection? To answer it, we use the PERCO framework, and here we hypothesize that salivary procalcitonin correlates with serum procalcitonin. Our second clinical question asks, could salivary procalcitonin accurately predict bacterial-induced systemic inflammation? To answer it, we use the PER framework, and we hypothesize that salivary procalcitonin can accurately predict bacterial-induced systemic inflammation. Our clinical implication is that salivary procalcitonin could indicate systemic bacterial infection and the need for antibiotic therapy. And to summarize, we plan to finish with all of our project on June next year. And I would like to thank you for your attention with a quote from Albert Einstein: "The most beautiful thing we can experience is the mysterious. It is the source of all true art and science." Thank you.
Regarding your first project, I'm curious that the location of the studies, how can these locations influence your results? And what I mean is, I think it's well known that based on the location, the different population has different bacterial, for example, in the biome or in the saliva, different bacteria. based on if it's an Asian population or a European population or a US population. Did you see any difference? Or how can you explain it? I'm just curious about it. Thank you.
Thank you for your question. So yes, one of our outcomes was the different abundance in different continents. There were not enough studies to assess exactly the difference between different population, but we could see, for example, in one study from Italy that the abundance of Fusobacterium nucleatum was higher in both the healthy group and the colorectal cancer patients, but unfortunately there are not enough studies to give evidence for that.
I have a question from the second project, actually. Mm-hmm. So, do you think that apart from culture, which we know is a gold standard but also takes time and all, do you think that procalcitonin is or can replace, for example, other biomarkers that are widely used for infection, like CRP?
I think that we know, thank you for your question, first of all. So we know that procalcitonin is more specific for bacterial infections, while CRP is less specific, is more, it is elevated in case of inflammation, as well as procalcitonin, but procalcitonin is, we believe that is much more accurate, and the aim eventually that it will replace it if it would be specific enough. Yes, that's it.
Thank you.
Thank you.